Hello, and welcome to the Health Data Ethics Podcast. I'm your host, Jenny Owens. Thanks for bearing with me as we had a brief delay. I had a vacation with my family last week. It was absolutely wonderful, and now I'm back this week with some new content. This week, I really wanted to spend some time talking with you about a very common kind of representation of data that happens in papers. Those of you on the academic side, feel free to tune this one out. I'm telling you things you already know. Those of you who are not on the academic side might have heard me reference in a previous video a table one, right? What is a table one? So a table one, briefly, is the first table, usually the first image or the first figure in your paper. And what it is a breakdown of your clinical population that the rest of the paper is a study of. So a table one is going to tell you really what it is that it's going to give you the ground level and the ground stakes for everything that comes after. It's going to tell you how large was this group that you tested your study on? What was their makeup demographically? How many men, how many women? How old were they? What kind of surgeries did they have? What kind of comorbidities did they have? Are there other confounding factors that you might have wanted to control for that, of course, then you measured and you documented about your data? So a table one is kind of, I like to think of it as the nutrition facts for your data. So as you're going into a paper, reading a study, you want to first get to know the group of people or mice, sometimes, if you do basic science research. You want to know the group of participants in the study, so that you can understand really deeply the questions that are being asked. So I have an example, right? So we recently got some statistical results back on a study that I was part of. Very excited about this. We were looking in particular at whether a particular gene interacted with the amount of opioids that a patient received after surgery. And the outcome of the study is not what we're going to talk about today, A, because it was underpowered, and B, because that's not the point. We want to talk about a table one. So in this table one, you can see that we have broken down our unweighted population. So we haven't done any sort of controlling. We haven't done any sort of like looking at whether groups are overrepresented or underrepresented, just our straight up raw numbers in our group. We're looking at the demographics. So we have their age in years, the average age of each group, group A, group B. We know how many of them are male and how many of them are not. We looked at ethnicity. So we looked at people who identified as white versus people who identified as non-white, and we're going to come back to this. And then we've got an ASA status, which is a measure of how complex the patient is. We also measured some comorbidities. We looked at diabetes, hypertension, COPD, because we wondered if perhaps some of these comorbidities might also impact a patient's pain control after their surgery. We looked at whether they had received preoperative opioids or not, and then we looked at their intraoperative factors. So what type of surgery did they have? How long was their surgery? And then did they get opioids during the surgery? So this is all information that tells you it gives you a nice picture of the cohort of patients that the study was done on. And the factors that we looked at and that we listed here are ones for which those are important elements in the story we're trying to tell in this paper. So we wanted to make sure that, for example, a patient with diabetes did not have any sort of unexpected interactions between their genetic type and the amount of opioids that they needed to adequately control their pain. Why am I talking about table ones? So I think being able to understand how the population that a study was performed on interacts with the results that the study purports to have proven. I hate the word proven. Anytime anybody tells me that a study proves something, I automatically get my shoulders up. But how you can bias your study results by selecting your population very carefully. And so a table one will tell you lots of useful information about how trustworthy and how applicable in other settings the results of this study are. In the previous podcast where I referenced a table one, I was discussing using a table one for data sets that are available for public use, right? To be able to digest and say, okay, I am looking for a group of patients that reflects the makeup of my particular hospital system. We can go back to Jenny's totally fictional hospital system, right? Jenny's totally fictional hospital system is a secondary care organization. So we don't do a lot of primary care. We don't do a lot of ambulatory visits. We do have robust inpatient floors. We have a good surgical center, but we are not the place if you have the means, the insurance that will pay for it, like a lot of people are electing to have heart surgeries at Cleveland Clinic because Cleveland Clinic is a wonderful place to have your heart surgery. We have some of the best surgeons in the world. People aren't coming to Jenny's totally fictional hospital to have their heart surgeries if they have other options. It's a nice hospital. We give great fictional care to fictional patients, but it's not the hospital of first resort. Jenny's fictional hospital system is more a hospital of medium to last resort. So when I look at this, right, if I'm looking for data that is applicable to my fictional health system, I'm going to think about, okay, what's the age, what's the socioeconomic status of the patients in these other studies? Are we looking at patients who have had a selection of multiple cardiac surgeons and are able to pick the best one, or are they going to go with the hospital that is closest to them that can get them in the soonest? Are we going to look at, I would like to look at, for a health data set that is representative of my health system, I want to make sure that the ethnic makeup is very similar. If we have a health system that sees predominantly, rich white folks for elective surgeries, if we have for example, a data set that comes out of, I don't know, like a plastic surgery clinic in Beverly Hills, might not be applicable to my health system in not Beverly Hills that is seeing patients of both genders and all sorts of demographic status. We also want to make sure that the mix of comorbidities is going to match. And this really depends on what it is that you're trying to do with your data, right? So when you're thinking about labeling a data set, when you're thinking about picking a data set that is applicable to your own situation, it helps to really understand your own population deeply so that you can match it then with a data set that does match. Or conversely, so that you can know if you're testing an algorithm, for example, that was trained on the data from a plastic surgery, plastic surgery office in Beverly Hills, you might want to think about, hey, what are going to be the differences? Where might I want to make sure that this data set is performing as well in my patients? Where might I expect it to diverge? Where might I expect this algorithm to be overfit to this particular population? And how do I expect that to show up when I run the same algorithm through my own data? So really, what a Table 1 is a tool that helps you understand the demographics of your particular patient data set. It can help you match the data set so that you get an algorithm that's trained on a similar data set to your own patient population. It can also help you understand where you might be looking for algorithm performance that is tuned to a different patient population. So Table 1s can be extraordinarily helpful. It's a really useful tool to help you understand your own data and your own patient population on a deeper level.